Dear viewers, I am Dr. Sunil Garg from Essentials of Acute Care. In this video, I am going to discuss positive and expiratory pressure, abbreviated as PEEP, which is used during positive pressure ventilation. PEEP is a maintenance of positive pressure at the end of expiration so alveoli does not collapse, or in other words, it recruits the closed alveoli in the diseased lung and prevents them from collapsing at the end of breath. The application of external PEEP has several advantages for the patient. It reduces trauma to the alveoli by preventing repeated opening and collapse with tidal ventilation. Hence, it reduces atelectrauma and biotrauma. It improves oxygenation by recruiting otherwise closed alveoli and by displacing extravascular lung water if there is pulmonary venous congestion as in pulmonary edema. It increases the functional residual capacity and improves ventilation perfusion mismatch. It increases the compliance of the lung by recruiting closed alveoli. Compliance is a relationship between the change in volume with a change in pressure in the lung. With PEEP, less pressure is needed to get the same volume of the air into the lung. PEEP also allows oxygen to be reduced, hence reducing risk of oxygen toxicity. It also helps in reducing the work of breathing in patients with obstructive airway disease, those who are on spontaneous ventilation mode, as less effort is required to trigger inspiration. In terms of cautions used during its administration, PEEP can cause some problem for those patients who have airway obstruction, like patients with asthma and those with COPD, especially if there is no spontaneous efforts. It may increase intrathoracic pressure, leading to fall in venous return and cardiac output, hence blood pressure. It may also increase intracranial pressure due to an increase in intrathoracic pressure. The value of minimum PEEP or initial PEEP is 5 cm of water for all ventilated patients, barring patients with obstructive airway disease, where initial value may vary between 0 to 5 cm of water. Optimizing PEEP is a controversial issue but should involve optimization of the oxygenation with minimal or no alteration in cardiac output or blood pressure. It is also important to ensure that there should not be any more injury to alveoli due to application of extrinsic PEEP. The aim is to avoid both overstretching injury due to hyperinflation and atelectrauma by preventing de-recruitment. It should always be individualized for a given patient. There is no agreed upon ideal method of determination of optimal PEEP. We should understand that optimal PEEP may change over time and an individual patient due to disease progression or positioning. Certain patients group may have different PEEP requirements, like in obesity, patients typically need higher PEEP than non-obese patients to maintain alveolar recruitment. In asthma, PEEP can be 0 or 2/3 of the measured auto PEEP. However, there is no high-level evidence for either approach. PEEP is preferred in spontaneous ventilation modes to reduce work of breathing. There are various methods to optimize PEEP and they are as per ARDS net ventilation strategy according to pressure volume loop analysis based on the concept of maximizing static compliance by recruiting alveoli, based on the concept of optimizing driving pressure and again by recruiting more alveoli, based on the concept of minimizing PaCO2 and EtCO2 gradient which is surrogate for the dead space, PEEP value which has lowest intrapulmonary shunt means highest SVO2, based on end-expiratory transpulmonary pressure measurement, and lastly based on electrical impedance tomography. Regarding the use of PEEP in ARDS patients, high PEEP is used as part of an open lung approach to ventilation for acute respiratory distress syndrome. Patients with recruitable lung are more likely to be PEEP responder and have improved oxygenation and or alveolar stability with an increase in PEEP. Not all ARDS patients are PEEP responsive, and the degree of lung recruitability in responders is variable. PEEP will cause less increase in intrathoracic pressure if lungs are poorly compliant, like in patients with severe ARDS. Overall, higher PEEP compared with lower PEEP is associated with improved mortality in ARDS patients. So to summarize, PEEP is the maintenance of positive pressure at the end of expiration to recruit the closed alveoli in the lung and prevents them from collapsing at the end of breath. If appropriately applied, it reduces ventilator-induced lung injury in addition to improving oxygenation and increase in the compliance of the lung. Optimizing PEEP is a controversial issue and there is no agreed upon ideal method of determination of optimal PEEP. Here I finish. Thanks for watching this video. Please do not forget to subscribe to this channel. See you soon in my next video on some very interesting topic. Till then, bye.